So you're all very welcome. For those of you who don't know me, my name is Pauline O'Reilly, and I'm a professor in the School of Nursing and Midwifery. And so you're all very welcome to our afternoon session. And we've titled it More Than Skin Deep. And I hope by the end of the session, you'll have a very good idea as to why we actually give it that title, or More Than Skin Deep. Okay? So the focus of our talk today will be on the development of a nuanced, bespoke quality of life outcome measure for patients, adults with Stevens-Johnson syndrome or toxic epidermal necrolysis. And you'll learn loads about this in the next 2 hours, so don't worry about all the terminology that we'll be using. We'll be asking, we have an exam at the end of it, so you better listen. So Stevens-Johnson syndrome, or SJS, and toxic epidermal necrolysis, or TEN, are acute dermatological skin conditions. And although we say they're acute conditions, our research and other research that we've been looking at would say that they're actually chronic conditions. And they're chronic conditions because of the multi-organ involvement and the consequential sequela as a result of that. And we were looking at, it was an underserviced area in research. And our preliminary work really was Sheila, myself, and Professor Bart Ramsey, we got together and we were thinking about what could we do in this area. So we were saying that we'll certainly try and do a little bit of groundwork, and Sheila will be mentioning that, so I won't overdo your lecture. So we decided eventually that we'd apply for HRB funding. And I set about doing that, and we were very successful that we actually got Health Research Board funding, the investigator-led project. Thrilled getting that, and that led us to the development of Paulton. I'll just introduce you to, this is just the team that are here today. There are lots of people, and some of you are here, and I'll be pointing you out later on. I'm good at that. These are the people that are here today that are presenting. Okay, so we have, me. You'll be sick of listening to me. So we have Dr. Sarah Walsh, and Sarah is a consultant dermatologist, and Sarah is in King's College Hospital in London. And Sarah, I've said this before, I couldn't have managed without Sarah. Sarah was absolutely, I could ring Sarah, email her at any stage, and I'd always get a response. So Sarah is now blushing, and you can't see her blushing in the background. Then we have Sheila Ryan. Sheila Ryan is an advanced nurse practitioner in University Hospital Limerick. Sheila, again, is my right-hand woman. And she's also a doctoral student here in the university, and both Pauline and I are her supervisors, and also Professor Donal Fortune. And we're after this now, she has to start working because she's had a break up to now. Then we have Rob Ahern. Rob and Phil Morrissey, two very important people in this whole project. And Phil and Rob worked with me for a good couple of years. We were in the thought processes of developing the whole thing. And my initial research, I suppose, I worked with Phil, and we were doing interviews. You were more had of people that I was interviewing, but then you became part of the steering group and PPI members. And without Robert or Phil's input, I couldn't have done it either. And last but not least, we've Professor Pauline Meskel, who is going to talk to you about the evidence synthesis in the development of the items. And Pauline is in the School of Nursing and Midwifery. So there was only one Pauline in this university a number of years ago. Now we have about 10 of them. Okay, so just a quick overview of what we're going to do. So Sarah's going to talk to you about the signs, symptoms, and management of Stevens-Johnson or toxic epidermal necrolysis. Then Sheila will talk about the nursing care of these patients, but particularly from a psychological perspective. Then Rob will talk about a patient, from a patient's perspective. Rob had SJS, and he's going to talk to us about what it was like for him. Phil is going to talk because she was a carer for her mother, who not only got it once, but twice. So again, Phil has an amount of information that she can impart in relation to what it was like to be a family member with somebody with SJS and TENS. Then the development of Qualton then is down to myself and Pauline. So I'll talk to you about the qualitative study. Pauline will talk about the evidence synthesis, where we developed our items, and then I'll bamboozle you with statistics. But Ailish is here, who will answer any difficult questions that you may pose. And if I look kind of stunned, I will look at Ailish. So we talk about the Delphi study, the consensus study, and the test-retest study that we did. So there was a hell of a lot of work. And then after that, I get Pauline to chair our panel session, and that's it. So I'll nicely now Emer is going to very nicely lead us in here. She's going to very discreetly turn down this, and Sarah will start talking. Now, Sarah, the floor is yours. You can hear us all.
I can, and I hope you can hear me as well.
Perfect, Sarah. Thank you.
Fantastic. So I'm just going to start sharing my screen. And I just want to check, can you see that as a presentation or can you see it as speaker view?
Presentation, Sarah.
Wonderful.
Yeah,
perfect. Yep. I'm all set up then. And well, thank you very much for that kind introduction, Pauline. And I also send my congratulations on your impending retirement. And you know, Pauline was kind enough to say she couldn't have done this without me, but really Pauline has undertaken spearheaded such an important project in developing this quality of life score. This is a huge unmet need for these patients, as we'll learn as we go through my presentation and others. And I know that the patients who participated from my centre in the development of this questionnaire have found it to be hugely valuable, and all agree that it will make the management of this chronic disease much, much easier and will enable us to target our interventions more effectively. So by definition, this presentation contains some images which may be distressing or shocking to many of you, because this is a very dramatic disease in its clinical presentation. So as I say, unfortunately, we've had to cut this out of the recording just because I don't necessarily have the permission of the patients to have this available after the event. But I do share my sincerest gratitude with the patients for allowing me to use their images in the process of educating others about this important condition. So this disease goes under a number of different terms, Stevens-Johnson syndrome, toxic epidermal necrolysis, but really these terms are best thought of as a severity spectrum, with Stevens-Johnson syndrome being at the milder end and toxic epidermal necrolysis being at the more severe end. And it is thankfully rare, somewhere in the region of about 5 to 8 cases per million population per year. It is life-threatening, and this is why we attach a great deal of importance to it as dermatologists, because there are not that many diseases, skin diseases, that we have that can cause mortality, but this is very much one of them. And the mortality can range from 10 up to 90% in the most severe cases. It is, as you might extrapolate from that, a really devastating condition, and it leads to a shattering of the patient's body image and a number of very serious sequelae, which we'll talk about during the course of the presentation. It is in adults overwhelmingly a drug-induced phenomenon, but in pediatric patients, in younger patients, it can be secondary to an innocuous viral infection or bacterial infection. But for our purposes today, we think of it as a drug-induced phenomenon, an idiosyncratic and unexpected reaction to a medication. Just a little bit about the history, and I know that we're going to hear a little bit more about this later on in the talks this afternoon, but it was the entity was first recognized by 2 pediatricians, one called Dr. Stevens and one called Dr. Johnson, hence the name, who noted this extensive and painful eruption of the skin, accompanied by crusting and soreness of the eyes and mouth in 2 patients following streptococcal infection. And then subsequently, the drug-induced form in adults was recognised by a Glaswegian dermatologist called Alan Lyle, who gave his name to the entity. And to this day, in France, toxic epidermal necrolysis is still called Lyle's disease, after this eminent dermatologist. So what does the patient present with? Well, this is what is quite frightening about this condition, because in its earliest stages, it can be quite innocuous looking. The patient may present to their GP with a sore throat, a stuffy nose, perhaps a slightly gritty feeling in their eye, They may have the beginnings of a rash, but certainly no blisters. But over the first 48 hours following the onset of these rather innocuous symptoms, you start to find that the skin begins to slough off. And this is due to necrosis or death of the epidermal cells, the epidermis being the outermost layer of the skin. And this causes problem enough when it occurs within the skin. But with SJS-TEN, we also find that the mucosal surfaces can be involved, and this includes the eyes, the mouth, the genital skin, and sometimes even the airways. And it really is a dermatological emergency. I think I'd like to tell you this story by illustrating it with a patient's journey. And this is a young lady who participated in our study, who I met for the first time in 2023. And she's here in the centre, an absolutely delightful girl who was working in IT. She had a dog, parents, a boyfriend. She was living an independent and happy life, was keen on exercise and dancing. And she began to suffer from insomnia, a little bit of sleeplessness over Christmas when she'd had a particularly stressful period at work. She took a prescription sleeping tablet, which was borrowed from someone else. And 5 days after taking the initial dose, she developed a sore throat, sore, gritty eyes, and began to feel very, very non-specifically unwell. 2 days later, she developed a rash, which she described as being exquisitely painful. And a mere 24 hours later, she developed blistering and the skin began to slough off. About 24 hours after that blistering, she was in intensive care with about 60 to 70% body surface area involvement, by which I mean about 60% of her epidermis had become necrotic or had died, and in certain parts was starting to slough off, exposing this light pink area, which is her dermis, which is normally covered completely by the epidermis. She also had ocular involvement of the airway, prominent genital involvement, and she was extremely sick with temperature, low blood pressure, and was requiring a lot of support from the intensive care team. Now, she was admitted to ITU, where she remained for 53 days, which is a long time by any stretch of the imagination. And this is what was going on at biological level in her skin. But just to simplify it a little bit, the drug is ingested and it is picked up by a T cell, one of the immune system effector cells, which develops an exaggerated immune response. And this releases chemicals which causes all of the epidermis, which is this upper layer of the skin, to become necrotic or to die. And when it dies, it separates from the underlying dermis, leading to the clinical appearance that you see here. The same process is going on in the mouth, the eyes, and the genital skin. And the importance of the mucosal sites, particularly the eyes and the genital skin, is because these are areas that can scar, and that is part of the reason for the consequences that these patients suffer once they are discharged from hospital. And our patient also had some airway involvement, and this is often hidden, so you can't see the airway. So we often ask our anaesthetic colleagues to have a look into the airway with a small camera, an endoscope, to see if a similar process as we see in the skin is going on in the airways, in the trachea. Because when these flaps of epidermis become loose, they can actually occlude or block off the airway, which, as you can imagine, has serious consequences for the patient. And one of the reasons this is something that we have to be very vigilant for is because ordinary imaging, like a chest X-ray, may be completely normal. Now, as you can imagine, these patients are very challenging to manage in a hospital setting. And managing a case of SJS-TEN is very much a team sport involving lots of different parties, principally dermatology, nursing colleagues, ophthalmology. We often involve gynecologists and urologists. I've mentioned the involvement of anaesthetic colleagues. We need microbiologists to give us advice about what antibiotic cover to give. We often ask our colleagues in oral medicine to attend. And psychologically, we do tend to try and involve colleagues from clinical psychology or psychiatry early in admission to try and address some of the issues which I'm going to speak about momentarily. And these are issues which have been brought to the fore in our Qual10 quality of life questionnaire. In terms of treatment, the mainstay of treatment, and I know that this is going to be spoken about a little bit later in one of the other presentations, is supportive therapy. You'll recall from the photographs I showed you earlier that this patient was looked after in intensive care, and this is really the best environment possible to care for these patients. Specialised dressings need to be used to protect the remaining skin and to care for the areas that are denuded of the epidermis. We also have to manage the patients in an environment that's slightly warmer than the average ward temperature. This is because when you lose your skin, you immediately become very shivery and cold, and to lower the metabolic burden so that your body doesn't have to concentrate on keeping its temperature at 37.5, we try and warm the environment in which these patients are cared for, and that can help with recovery and with healing. We apply lots and lots of greasy emollients, moisturizers, to act as a sort of a barrier between the skin and the outside world, because the layer that would ordinarily be doing this, the epidermis, is not present or not working as well as it should. And in recent years, we have started to look a little bit more at active therapies that can be given to try and interrupt this dangerous inflammatory cascade that has been triggered by an unexpected reaction to a medication. I've been involved the last, 17 years with writing guidelines for the management of SJS-TEN under the auspices of the British Association of Dermatologists. Our first guideline was written in 2016, and we are just in the closing stages of writing an update to these guidelines to reflect the new developments that have taken place in this area, predominantly in the domain of active therapy. So hopefully we can improve outcomes for these patients. The guidelines give really helpful, practical tips on how to receive these patients in hospital, what the therapeutic and the investigative priorities are when they come in, which investigations should be ordered, which specialists should be run as a priority. And I would urge anybody who's likely to be involved in the care of these patients to read these guidelines, because they very much are designed to be user-friendly, not ivory tower, tertiary centre stuff. It's really stuff that, you know, should be deliverable in any healthcare setting, secondary care. One of the big changes for the revised guidelines, which are going to be published imminently in the next couple of months, is that they do reflect the development of some more advanced treatments for this condition, in which we try and interrupt that inflammatory cascade. And there's a particular treatment called etanercept, which blocks one of the drivers of inflammation called tumor necrosis factor. And this was investigated in a big study done in Taiwan of 96 patients, and it showed that when you gave etanercept early in the course of disease, that these patients healed more quickly, got out of hospital a bit faster, and had fewer consequences to their illness. And so we're hopeful that that will begin to be used once we publish our guidelines, because at present it's very difficult to get non-commissioned treatments to patients. Now, going back to our lovely patient, she did survive and she came to healing. You can see that there's pretty significant pigmentary or colour change in the skin when she healed, which is normal for patients with skin of colour. You can also appreciate up here that there has been some shedding of the nails, which again is something that happens in these patients. But getting out of hospital is really only the beginning of a very long journey, which is where Qual10 comes in. And consequences of SJS-TEN have been well documented in the literature. They certainly occur in the skin, but they may also involve eyes, the mouth, the genital skin, and internal organs. Now, you can see, particularly in skin of colour, that initial pigmentary disturbance does tend to improve with time, and that's just the body's natural healing ability. So with lots of moisturiser, this patient has got a better cosmetic result. She is now not reliant any longer on her feeding tube, which was required for 6 months after discharge. She had to be fed through a tube directly into the stomach because her swallow was so weak, having been intubated for 50 odd days. And this was obviously very distressing for a young woman. When she was discharged from hospital, she also developed a complication that can follow any acute illness or even a pregnancy, called telogen effluvium, which is where because the body has directed all its reserves and energy to healing, and clearly this was a huge body surface area to have to heal, it diverts nutrients away from the hair and all the hair falls out. Happily, again, this did recover, but at the time, highly distressing for this young woman. Her nails, she shed about 80% of her finger and toenails, and even as they have grown back, they have not grown back as they would ordinarily, and that is because of the amount of inflammation that had occurred at the nail matrix, which are the cells that produce the hard bit of the nail just behind the nail fold. She also developed some prominent sebaceous glands and little sweat glands, which were pushing out because of the damage to her skin from the inflammation. She's been able to get some laser therapy for that. She came to see me, we followed these patients up quite closely, and she came to see me about a month after discharge, and she told me her periods hadn't started again, which I partly expected after such an acute illness. But when she still hadn't started her periods after 3 months, I got an ultrasound, and it turned out that she had a blockage of her cervix. The neck of the womb was blocked such that her period material, which is called the products of menses, could not escape from the uterus. And that is because the cervix had become scarred due to involvement during the acute phase of illness. She had to undergo an opening of the cervix, which was under local anaesthetic, but again, distressing, to reinstate her periods. So you can see this woman has really been through a huge amount physically in terms of consequences. And this is to not even touch upon the psychological consequences that many of these patients develop. I mean, I would look after many of these patients over the last 17 years, and I can attest to the fact that depression, anxiety, and a post-traumatic stress disorder phenomenon are, common in this cohort of patients. And part of our work has been to see what we can do to try and minimize the psychological sequelae. We know, for example, that it's very important that pain control in the acute phase is prioritized, because if you can manage the pain relief well in the acute phase, then these patients are less likely to get PTSD. We've had a recent paper showing that. And I think this is why this questionnaire, this quality of life questionnaire, is so important, because you can see this is a unique cohort of patients who need and deserve a bespoke quality of life tool. And that is what we have set out to design. That, I think, is what we've come up with. And I look forward to hearing more about that over the course of the afternoon. Many thanks for your attention.
Thank you, Sarah. You can hear the applause. Thank you very much for that. So Sarah is going to stay with us throughout the session and will be available for the panel discussion as well. So we're now at this stage, I'd like to introduce Sheila Ryan. And as I said, Sheila is an advanced nurse practitioner in University Hospital Limerick in dermatology. And Sheila is going to talk to you about the nursing care of patients with SJS and TENS, particularly from a psychological perspective. So Sheila, thank you. I'll hand you over there.
Lovely. Thank you very much. So as Pauline said, I'm going to speak on the nursing care of patients with Stevens-Johnson syndrome and toxic epidermal necrolysis. And like the previous presentation, this too will have clinical images which are potentially distressing. So, as Sarah has been saying, this is a highly visible disease. There's no getting away from it. Patients will present with blisters, followed by skin loss, hemorrhage, and also, as Sarah also alluded to, we get concerned about the mucosal involvement, especially in the eyes. And it's a rapidly evolving condition. I've seen this happen within hours to patients. So just to show you how fragile the skin is, this is a patient of mine just before we turned her. And this is the impact of just laying on the pillow during the turn. So that just highlights how exquisitely fragile the skin is. Again, I'm going to talk about Alan Lyle, the Scottish dermatologist who described TEN. And in 1956, if you read the document, he gives a case history of 4 patients with TEN. And he described patient number 4. He gives a very nice description of how that patient was recalled by the very skilled nursing care. And he refers to the use of Complan, which was the nutrition of choice at the time, and a specialist turning bed that they used, the MSA turning bed. And he also makes reference here down to the ophthalmologist who preserved the patient's eyes with their expertise. So Lyle's description, and it's not really talked about, spoke at that time about the dedicated trained staff, the patient environment, nutrition, and care of the organs, especially the eyes. So we have that. So in a more recent paper, then Hansen and Betcourt set out further guidance on this. So they describe supportive nursing care, getting the patient to a specialized center, and that's defined as an area, a burn center or an ICU with dermatology or plastics support. Nursing care involving skin assessment and wound care, infection control, fluid and nutrition replacement, pain and comfort management, and looking at specialty areas. Now, they define their specialty areas in the main about the care of the mucosal involvement, so that's the eyes, the mouth, and the genital urinary areas, but they also mention briefly psychological care. So this is what supportive nursing care looks like in the Irish setting. Patients are nursed on a specialist bed where we can adjust their position by control. We have burns vests. As nursing care, we also will support them nutritionally, and where needed then respiratory support as well. So they have a very intensive skincare regime with specialized dressings. Now, this will vary from country to country. In Ireland, we use these burns vests in combination with silicone dressings. They use different things in different countries. But common to us all is the pain relief the patients will get. Because if that's badly managed at the time of dressing, that leaves the patient with those long fear, anxiety, and that lives for many years after our initial dressing. So common to us all, irrespective of, we can all argue about different dressings, pain relief and patient comfort is of prior importance. In dermatology, we favor the aspiration of blisters, so to preserve the blister roof. And this looks quite a painful procedure, but it's not. But you have to reassure a patient, because if you're coming to a patient with a needle drawing fluids, it looks quite painful. It takes a little bit of reassurance, and that's a lot of the work of myself and the nursing team that I work with, is reassuring the patient and telling them what we're going to do. And we do this very much at the patient's own pace. Things that we would consider as kind of normal everyday objects within a hospital room are now huge hazards for patients. The wristband can cause, if it's not protected with dressings underneath, can cause friction and induce blisters. The IV cannula site, the adhesive that's used to secure that, again, if that's removed uncontrolled, that will take skin with it. So with me, we'll use silicones dressings underneath. The ECG leads, which we need to monitor the patient's heart rate, again, if they're manually removed, they can take skin with them. The patient's own products too can also harm the skin. And I now, when I've got patients presenting, I will do a jewelry check, and it's not to check out the rings, and it's to remove those or earrings or jewelry that might be harmful later on. Because in the preceding days, in the aftermath, there is edema comes in due to drop of albumin. So we try and avoid now the traumatic ring removal. So this is a patient to me, a nice picture. It's nice to have some nice pictures. This is a patient of mine who survived Stevens-Johnson syndrome. And this picture was taken at her request. We had 2 weeks of me taking various pictures of her and all different angles of her skin and putting on various different dressings. And she said to me, Sheila, can we have one decent picture that we can both look back and say, we got through this and this was that we can both look back on and this is the picture. But it brought home to me, you know, what the patients put up with, and like, you know, the sense of the humor and the stoicism that the patient has to go through to keep their personhood with all this happening. So a lot of my role involves liaison with different people, because usually when this happens, when the condition happens, it's new for everybody. So I will be liaising with nursing staff, be they in the ED department, outpatients, or the wards, and the ICU staff, and the same with the medical staff teams. And I also act as a liaison to patients' relatives and the patient, telling them what's likely going to happen next, and putting a little bit of English on all that's said. So that's what I do. So in 2017, this paper was written by one of the nurses, Debbie Brown, that had been involved in the initial BAD guidelines that Sarah spoke about. And in that commentary, she noted that there was psychological care of the patient wasn't really addressed in those initial guidelines. And these guidelines had never been written before, and there's a lot. There was a lot to capture in the guidelines. So that prompted us to, I don't know why that's moved, but anyhow, that prompted us to look at the psychological impact of Stevens-Johnson's syndrome. And that's where I linked up with Pauline, and we did a critically appraised topic there. And in an integrated review, we found that patients, that there was a dart of research, but the knowledge that was out there was that patients experienced fear, stress, and had symptoms aligned to PTSD. And also that there was a lack of information or knowledge amongst healthcare professionals. So that was what we learned there. Then we did we looked further, and we did a integrated review looking at Burns patients and Stevens-Johnson's patients about psychotherapy interventions that was used with those groups. Again, nothing was there at the time on the Stevens-Johnson's population, and we found 17 studies in the Burns literature. And in those studies, most of them kind of were at the time, and they showed a reduction in pain scores, but they can be divided into empirical studies and alternative. And the empirical studies was where relaxation, cognitive behavioral therapy, and hypnosis was used, And the alternative studies varied from dog therapy to music to massage to nursing rehab. And also there was two very nice qualitative papers on the care environment and the caring relationship and how patients responded to that. So they were able to recognize the centers where people around them knew what they were doing, and they were able to recognize the nurses and medical staff that knew and went that extra mile to help them. So we then did our own research study where patients, family members, and healthcare practitioners, where we did a qualitative study using emotional touch points and looking at the people's experience of Stevens-Johnson syndrome. And in that, with 12 participants, and again, the profound impact of Stevens-Johnson syndrome was highlighted both by the patients, the relatives, which you'd expect, but also with the healthcare professionals. They also found it a very huge, impactful event. The care that matters, it varied from the two sites. The healthcare professionals were all about getting the patient to the ICU department. The patient was the care that they responded to was the expertise and where people valued what was happening to them. And going home was overwhelming, and there was a fear of recurrence for the patient group. So I'm going to conclude with Alan Lyle again. And he spoke about that if the patient could survive the organ hit, the next thing that was important to survival was the skilled nursing care, but also the patient's psychological well-being and courage and endurance to go through and survive the event. So there are my references, and thank you very much.
And very next, Eva, thank you. Poor Emer was stuck in the corner. Okay, so now I'm going to hand you over now to Robert Ahern, or Rob Ahern. And Rob is part of our steering committee for Qualton. He's a PPI member. So I know Rob, oh gosh, a good couple of years now. And so Rob, maybe if you come up here, Rob, so that you'll be able to, everyone will be able to hear you. And we get Emer, you can move in and out. Yeah. So Rob is going to talk to us about the impact that it had on his life.
Yep.
And maybe just a little bit about when you know, what you got and when you got it, none of it.
Yeah.
So I hand you over to Rob.
Yeah, perfect. Hi, everyone. So it was about 20 years ago. I was 15 when it first started. So I was actually trying to, I had an issue with my jaw. I was getting pains in my jaw. And I was at every specialist around Ireland trying to figure out what it was. So I ended up going to a neurologist there in Cork who said, there's no pain there. So he prescribed me a medication called Tegretol. So I got home that evening and I took my first dose of Tegretol. And it was that night, my mother came in, she could hear me screeching, and she came into me, I was shaking like a leaf, and she could turn on the light straight away. She could see that there was skin off my lips coming off, peeling off, and blisters started appearing on my cheek. So the GP told me to go straight into Clonmel Hospital, where I was actually very fortunate. There was a local doctor there that had seen this before. I knew exactly what it was, so he called an ambulance to bring me up to Crumlin Hospital. So I was in the burns victim unit there for six weeks. So for that 6 weeks, like blisters within days, a rash over my whole body, blisters everywhere, lips down my throat, up my nostrils, just anywhere you can think of. And I wasn't able to walk because my soles of my feet were all blistered up, and then I was bedbound for weeks. So there I was under, I had morphine in one arm, had biotics in another, and I was fed through a tube as well. I was in isolation as well because obviously with the skin being susceptible to infection, so like my family and friends couldn't come into me either for a while. So as Sheila mentioned, like the care of it was, so I was bathed in just moisturizers and anything can control an infection, and for that time. So after for 6 weeks anyway, I did recover well. As you can imagine, the top layer of my skin had come off, so I had to be very careful in the sun. So factor 50 every day, for well over a year until I built up the tolerance and that. Even from now, like I've a fear of taking medication because this happened again. Like I had suffered from anxiety and that from it, where my doctor had wants to prescribe me some medication for that, but actually after looking at the symptoms, Stephen Johnson's syndrome was always a symptom there, so I never took anything like that in the end. It had affected my education because I'd missed a lot of school, so I was trying to get back into that. So missed about 3 or 4 months of school, and just general anxiety as well. Because of the trauma on my skin actually developed psoriasis as well, and that affected my whole body. So I was battling with that it was really intense for 6 to 8 years. Or you can imagine school, getting changed in PE. I was quite self-conscious, and also it scarred my eyelids. So I kept getting recurrent cysts that I had to get surgery removed as well, because it would have scarred my eye glands and that. So thankfully I'm not getting that anymore. And yeah, in general, it had been effect on just my fear of medication and preventing from this ever happening again. There's that there. But yeah, in general, yeah, it was a horrific experience for me and my family as well. And yeah, and yeah, at the moment, like I'm still fearful of it happening again. So I'm kind of, I think for the first 2 years I didn't even take a Panadol. So I am taking Panadol now, but it doesn't stretch far from that. Yeah. But yeah, that was just kind of my story from it. And I was once going back to a dermatologist and just checking up on it. And actually, I met Sheila actually in the hospital here to help with my psoriasis, and then that's how I got involved in this research study as well. So yeah, that's it for me.
Yeah, Robert, sorry, Nick.
Yeah, good on.
Thank you, Robert. Yeah, and that's not easy to talk about. You know, it is hard to talk about something that you've been through that's been very traumatic. So thank you very much, Robert. Now we're going to hear Phil Morris. Phil is well able to talk. She said, I'm afraid to talk.
I'm going to read from a story now. I'm going to say the rest. Okay.
So Phil, we'll no, Phil has no, you're all right, Emer, she has no, yeah. So Phil is going to ad-lib it or read from her script.
I'm reading from my script.
So Phil Morris, as I said, it was a carer for her mother who contracted SGS twice and TENS, yeah. So Phil will talk to you about what it was like to be a carer and to see her mother going through TENS. Thank you, Phil.
And as I said, I'll read from the script because I don't want to be fluffing things up. So
are you all right for water, Phil?
I'm fine, thanks, Colleen. A gin and tonic would be nice. No, so my name is Phil, and I just want to say many thanks to Pauline and Sheila and all the team for getting me involved in this. And I just want to tell you a small little story. During May 2018, my mum presented to A&E with sepsis. And as you could appreciate, this was a very stressful to hear this diagnosis and prognosis at the time. Treatment began for the sepsis, and signs of improvement initially were good until a sunburnt-eyed rat decided to make itself present. As the hours progressed, so did this rat. It had reached profound severe status in a short length of time. A sense of urgency for the dermatology department, and on visual inspection, symptoms diagnosed Steve Johnson's and subsequently TENS. We had thought the sepsis was the invader, but the new enemy was this, TENS. Proved to be the biggest challenge of all, physically, psychologically, and emotionally. The anxiety, palpable. And when you get called by the consultant, beg your pardon, to speak outside the room, then the psychological effects hit. Your mouth becomes this metallic taste, your heart is racing, and you fear for the person that's inside, your loved one, who has no words, there's no words to describe what you can say to them. Your mother is covered from head to toe. Your mummy is like an Egyptian mummy because she's covered from head to toe. So the visuals were very hard at the time. The eyes, and she'd already had lost one eye, and her greatest fear was to lose the second eye. Her mouth was very sore, and like the ladies, they are described all down genital areas, the whole lot. And after that, took an awful lot of healing afterwards. And as we had the seesaw of emotions, from happiness to sadness, the fear that this was going to, like Robert said, the recurrence again, taking a tablet. You're looking at this person all the time to see if I give him a Panadol, and if you see even some bit of a flush, and you're saying, oh my God, it's happening again. And unfortunately for Mem, it did happen again in the same year. So she got Steve Johnson's, she got TENS, she was discharged from hospital, she got sepsis again, and then she got Steve Johnson again. For her, I'll just read off script now. For her, it was a very traumatizing time for her. She would say her exact words was, it was hell on earth. And my mother had suffered from social phobia, so even the hospital setting, not her mind being trapped, all she could do was lay there and breathe. So she had definitely the psychological and the emotional aspects of the whole lot. And it was traumatizing for everyone, because what can you do? You don't really know what to say to the person to make him feel good. So that's my experience. I thank everyone in the team for approaching me. It's almost cathartic to talk about it at this stage. And Pauline, only for you, she said, come on, you could do it. Because I said, I can't do it. I can't stand up here and talk to people. She says, you can. You're willing to speak there now. Come on. She's like, come on. And I thank you, and the very best in your retirement. I hope you're very happy with it. And thank you for listening. Thank you very much.
Thank you, Phil. And again, that's not easy either to talk about. It isn't easy. Yeah, well done. Well done. So I'm going to segue nicely now into this, and it's great having Emer here doing all the techie jobs, because it's amazing actually. You kind of, when you're trying to talk, you try to forget the technology. If there's any glitch, marmot, or anything like that, you're in an awful state about it. So Emer, thank you very much. No, it's not. Yeah, number 2, that's it. Can we see? Is it? That's it. Perfect. Thank you. Yeah. Wonderful. Lovely. Okay, so now we're building up the story nicely here. So as I said to you, we titled the session More Than Skin Deep. You're now beginning to see from the talk that Sarah gave you, you heard about the devastating, again, condition, the impact, the management of it. From Sheila's perspective, from the nursing care perspective, you're beginning to see, for the poor patient in that bed, to be traumatized, losing their skin, people worried looking around them. So it is quite a traumatic experience. You heard it from Rob, his own personal experience, what it was like. You've heard it from Phil, again, having been with her mother, watching her, seeing the traumatic impact that it had in her life. So whilst these patients were very well cared for in the hospital setting from a physiological point of view, and were managed very well, that led us, when I linked in with Sheila, when we linked in together and Bart, we were talking about, well, the psychological care of these patients really is not being dealt with. And as I said to you at the beginning, it was a very much underserviced area of research. So there is no good saying we think the psychological care isn't dealt with. So I, as the person coming in with the old academic hat, said, well, we need to work from the premise I know rather than I think. So we were looking, we needed to look at the evidence to see what did the evidence actually tell us about it. And Sheila mentioned that we did our review, our systematic review on the psychological care, and we looked to see is there anything out there? We were beginning to see there's very little out there in SGS in terms of psychological management. So I think it was around COVID time, we got our heads together. I said, I don't know these people. Get me in contact. I said it to Bart and Sheila, and I think, Sarah, you were on board. I said, get me in contact with the people that I've been writing about. Saskia Ingenhouse Oro, Ronnie Dudiak-Gad, Chris Bunker. I need these people on board. I can do a certain amount. I'm good at getting a project. I'm good at research. But I don't know these people. I need to be able to be put in contact with these people to get the work done. So we put our heads together upstairs in my little office, meeting these people, these gurus. They didn't know me from Adam. I didn't really know them. So it was trying to build up a trust online, which wasn't easy either. But I think they eventually got to see, I think Pauline will do what she said she does, okay? And I think by that osmosis, the people were, bought into it. So I said, look, you can't do any research unless you get funding. And we had got seed funding from actually the HRI to do the preliminary work. I said, I can try and put a project together, because I was after finishing as being a head of department, and that's such an easy job. You have nothing to do, and when you finish it, you just want to lay back again. So as a glutton for punishment, I decided, well, you know what, I'm going to do more research now, apply for the old a decent piece of research. So I was nervous doing this as well, because you hadn't ever really applied for big funding like this before. So I had the group together. We initially thought about developing a meditation. Professor Bart Ramsey was big into meditation, and Sheila, by again proxy, was into it as well. I needed it badly. And we initially, that's what we were doing. I was writing a project for meditation, and then and developing an outcome measure. And I remember Professor Anne McFarlane was absolutely fantastic, because Anne was a member of our team. I'll talk about that in a second. And she said, Paula, you can't do everything. You'll have to cut it down. So I went away on holidays feeling great, and came back and you tore us asunder, which was wonderful. And I had to rejig it all again and write it as we were going to develop an outcome measure. So the whole introduction and everything had to change, but it was brilliant. That's what made it. So we had a great team. Some of you are here today. I can see Ailish Hannigan, Professor Ailish Hannigan, statistician. Brilliant, absolutely brilliant. Professor Anne McFarlane, we'd Liz with our searches. We had Isabel DeLine, we had Louise, we've all the people that I mentioned. So these were, I hope I haven't left out anyone. We had Reg for our postdoctoral researcher. So it was absolutely fantastic. So we were successful. We got the funding, which was brilliant. And somebody said to me before, Pauline, it's wonderful getting funding, but it's another thing actually doing what you said you were supposed to do. So you're actually in a high where you get this 450,000 or whatever it is, and then you have to produce the work. Okay, so that led us nicely. There's our nice team. Professor Donald Fortune isn't here with us today, but Donald was a great part of our team as well. And failure there up in lights. We have Saskia Ingenhouse Ora, and we had Ronnie Dudiak-Gad. You can't do work in isolation. Every person in that group had a role. And whilst I may have led it, as I said, I needed to have an input from all of these people as well. And I kept the project going together. And it was an absolutely wonderful project to be involved in. I absolutely and utterly loved being in it. At times I could have maybe given up on it, but I didn't. So it was a 3-year project. And the first year, what we were doing here, we were going to develop an outcome measure, a quality of life outcome measure. So that we followed the De Villis and Moking's literature in developing outcome measures. So the first part of developing an outcome measure is the development of items. So the development of items was based on having interviews with key informants, evidence synthesis, doing an umbrella review, doing a mixed methods review, which Pauline will be talking about, Then you have your items developed, then you have to gain a consensus, so you need to do a Delphi study, and then the third year was doing your retest study or your validation study. So a very easy study to do. Okay, so what I'm going to talk to you today is about the qualitative study or the interviews with the key informants. I was very passionate about all of this research. Anyone that knows me knows that I'm very passionate about this research and I like to do it very well. And there is and Raj will aside by this, you know, the devil is in the detail and you have to do it to the end. Because people give you their time when you're interviewing them, and it is incumbent on you as the researcher to ensure that you acknowledge what they say and that you pass that message on to the right fora, be that a good journal and clinicians. You need this research to have impact. So the first, the qualitative study, I followed Sally Thorne because I like Sally Thorne, and I followed her descriptive, interpretive, qualitative design methodology. And again, writing up our paper, obviously the same thing when I was doing the research, we follow the standards for reporting qualitative research. The sampling and recruitment, I could spend 2 hours talking about recruitment and sampling. As you can imagine, with a rare condition, it isn't easy. So the inclusion criteria it was only adults, so you had to be over 18 and you had to have a verified clinical diagnosis of SGS or TENS. And the exclusion criteria were adults with a pre-existing diagnosis of an enduring mental illness or a neurological disease or an intellectual disability that was judged by the treating clinicians to disallow or affect capacity to provide informed consent. I don't know who that is, but we'll ignore them. So I had to apply for ethical approval for the study. This was challenging as well. I could spend another couple of hours talking about ethical. You think all you're doing is interviewing, doing your statistics. Ethics applications take a hell of a long time to try and complete and to ensure that you're meeting all the different areas. I needed to recruit participants in a very rare condition. Sarah, and I'm sure you're listening, and Sarah was fantastic. So Sarah was my link with the UK, and Sarah had links then with Saskia Ingenhouse-Oro. Saskia was on board. So I got eventually, I'd say about 6 months it took to get the ethical approval through from the France. Any French people here? Good. The bureaucracy in France, lads, is on bloody real. It is really and truly is unreal. So that was the first and only time that I got ethical approval. After that, it went downhill. Okay, so we got ethical approval, but it was very specific approval. So much so that it ended up, I interviewed the 15 patients, or adults with SGS and TENS, and Saskia interviewed 3, but I only got the anonymized data from them, which was fantastic. So actually, I need a little drink now. So to start off with then, we had the purpose of sample with 18, 5 males and 13 females. And that's even though there's an equal occurrence between male and female in SGS and TENS. You do find that women tend to, acquiesce or, agree to be interviewed or partake in Delphi studies was the same thing. So I used a semi-structured questionnaire, and they were just basically some of the questions that I used. I acted on the cues of the patients as well. So when they said something that was very pertinent to them, I asked more questions. But by and large, I was asking questions in relation to how they felt about themselves, how they saw themselves, how it affected their lives, their social lives, their intimate lives, their relationships, and all of that. So there was a lot of questions. And even Rob, you mentioned it, fear of medication. I had read from the other studies that we had done, a lot of these patients, obviously, because it's drug-induced, fear medication, they feel fear going into hospitals, they fear healthcare practitioners as well. So I asked questions around that area as well. I knew that when we were going to develop Quantum, there was going to be items that were related to these areas, because that is what was coming up in my previous research and also in these interviews as well. I took each one of these interviews, each one of these people, I can still picture them in front of me. I can still hear them. And I can say that these people were thrilled that I was asking them questions. They were delighted that somebody was interested in this area that nobody had really asked anything about in relation to the psychological impact. So I took these very seriously, and I think it was the relationship that I built up with these patients only for that hour was powerful, because I could have written about 4 papers from the data that I got from the interviews with these people. I had transcripts that could have gone on for maybe 12, 13, 14 pages from one person. I could have 20 pages in another. I had one interview that actually went on for an hour and a half. So they were really prolific interviews. So I won't go into the analysis, but I analysed them inductively using content analysis. And content analysis was the best method for me, because I wanted it something that could be aligned to using the evidence and using the information, that I could use it for the development of quality and for policy and all of that. So this is very simply I had themes. I had 2 themes and I had categories. I won't even go into it. I had subcategories as well, but I won't mention them today now. I just talk about the categories. So the first theme was the psychological impact, or the psychosocial impact, and the second theme was the chronicity of sequelae. So in the first theme then, the psychosocial impact, the first category was the self and others. So the areas that aligned to this category were how people were feeling anxious, depressed, they had flashbacks, their self-esteem was affected, their self-image was affected, their lives were traumatized and they were devastated. This particular young girl, she was a lovely, lovely young lady. I think she was in second year doing a dietetics degree in London, and she had developed lupus. She was put on prednisolone, and because she had gastric reflux, she was put on lansoprazole and had an acute reaction to this. She was in intensive care for, again, I think it was about 3 months. And as she said to me, Pauline, I was in a bubble when I was in intensive care. I was so well looked after. But her self-image, like all of us, it's very important. She lost her hair, her skin was, she lost her skin, her nails. And again, as Sarah said, the nails didn't grow back properly. All her hair gone now, it's growing back, thankfully. But it was dead. It was absolutely traumatic for her. And she had many more exams she gave me. She missed out on her education as well, because she was in second year, so she had to go in, she lost out in a year, different groups and all of that. So many, many different impacts. Another category here was a changed perspective in life. This lady, again, it took me a while to get back into things and struggles. This particular person, she was a lovely lady. Again, she had a baby about a year and a half after she had been diagnosed with TENS. She had a bipolar condition. She was put on a new medication and reacted to it as well. Traumatic impact in her life, devastated. She had a really good high-powered job. She wasn't able, for the stress, she had to give it up. She has still to this day a deep fear of medication, which has affected her in terms of her bipolar. She is petrified that her daughter will get this, even though, the genetic, really, there's a very low chance that will happen. She's frightened of going to hospitals, all of that. The next patient there said, I think I hadn't had so many struggles. I possibly would have done my PhD. Very bright lady. Again, it was an over-the-counter medication. I think it was a cough bottle when she was a young girl. Oh my God, traumatic impacts in her life. She's clinically blind. Very bright girl. Again, it affected what she could do in life. She tried to do different courses, did degrees. She did psychotherapy, but she told me she wanted to go on and do so many other things. The next patient here, in terms of change perspective, it has completely and utterly changed my life. This woman stood out for me as well. She was 86 years of age, a lovely woman, had a great social life. She drove, she was independent. She got a very bad pneumonia, a bit like your mom there, Phil. She developed a sepsis, was put on a sulfonamide and reacted to it, and ended up with TENS in intensive care unit. No longer, she couldn't drive her car. She said she went down one time from her apartment, sat into the car, and she couldn't turn on the ignition. So she was so delighted again that we were doing something from a psychological perspective. In relation to the second theme, which was the chronicity of sequela and the multi-organ involvement, so you're now beginning to see not only is it's more than an acute condition, it's chronic, and there's multi-organ involvement. This girl is the same girl here again. Her corneas were badly scarred. The amniotic membrane surgery was done and it was successful. I remember she telling me, Pauline, it was successful. And then I gradually started to lose my sight. And by the time I was 22, I was blind. She had hope. She said, Pauline, I don't want to join any organizations for the blind because I could see, I knew what it was like I knew what life was like. I could see it. People who are born blind don't have that. So she had a lot of deep trauma in relation to that. And again, affecting personal lives, intimate relationships, fear of engaging with people, fear of, body image and all of that. So all of these things were very important. The implications of the diagnosis. This lady, again, that's the same lady that had the little baby about a year after she had the twins, and she was saying they were very good, they were great, the dermatologists were fantastic, the ophthalmologist was great, but nobody really asked me how I was doing. Nobody said to me, how are you feeling? What is it like for you psychologically? So very good from a physiological perspective, not really from the psychological perspective. And again, the fear of taking medication. And Rob, you alluded to that. Panadol is, about all you will take at the moment. So fear of taking, and you can rightly understand why people are frightened. And again, this lady here, oh my God, I question everything. She was a very funny lady, actually. She had contracted it, again, I think it was an infection and an antibiotic. And she said she's meticulous about if she ever gets sick when she goes into hospital. She follows every nurse, what they're doing, and doctors. She questions everything. And they become very knowledgeable and only right. So she's petrified in case people don't listen to her. And she said, I'm sure I'm their greatest nightmare. So I think just being told that it's actually happening, because the information that people got, being told what was going on, was very, very important to them. And that was another thing that came out, the implications in terms giving the information, titrating the information, giving the right information at the right time, and being told what was going on. And all of that was important. So I was beginning to see through the themes, through the categories and through the subcategories, there was a lot of information that could be used to just start developing the items. So we started then, the findings from this particular study, not alone did we develop the preliminary items from it, but we were beginning to see this paper. There's a lot of really wealth of information here that can be used by clinicians, that can again, make it very obvious and overt to clinicians. These people need to be listened to. They need to be listened to in terms of their psychological well-being. Please do something about it. So we were beginning to set the scene, and it was important that we try and publish the paper in a good dermatological journal. So we published that qualitative study in the British Journal of Dermatology. We were beginning to see that it was having an extreme significant impact on all the different quality of life domains, including psychological, physical, social, educational, and occupational. We were beginning to see what we needed here was the psychological follow-up, and a quality of life assessment was needed when this patient is discharged, and on follow-up care as well. Again, increasing awareness about the signs and symptoms. That was another thing. And as Sarah mentioned it, you mentioned it, Sheila, that sometimes if a clinician, a nurse, or a doctor may not have experienced or seen SGS or TENS before, again, they're not aware what are the signs and symptoms. So you need to be clued in, and having information is really, really important. So the more information you get out there in the right area, the better. So that was just a little synopsis on the qualitative study that we did. And the paper, as I said, there's a lot more exemplars in the paper. I use different ones here. So it's, you can read that paper anytime you like, but I think it was very good, as I said, for the patients to hear And I sent that paper actually on to a few of the patients. They contacted me back. They contacted me. And so it was absolutely great to send that paper out to people as well. So there's my references, and that's the qualitative element of it. So you're now beginning to get the picture. So I'm going to hand you over now to Pauline, and Pauline will talk about the development of items from an evidence synthesis perspective. And Pauline, and I'll give you the thing there.
Cheers.
Yep. So thank you, Pauline, please.
Thank you. Hi, everybody. Yeah, that's it. Thanks a minute. Afternoon, everybody. And I suppose I'm going to follow on from what Pauline has said. So to date, we've had a picture of the clinical picture of SJS in 10 from Sarah and from Sheila, giving you the clinical picture. Then we had Rob and Phil giving you the individual's experiences, and Pauline following up on that with details of the qualitative study and the aspects of that. So I'm going to follow on now, as Pauline said, with the evidence synthesis piece, because that's the third leg of the stool. So you're looking at the clinical picture, the patient's perspectives, experiences. So now we're looking at the literature. So, and as Pauline highlighted in one of her slides, we looked at DeValis, which was the framework for developing a new instrument. And in DeValis's framework, one of the things he highlights at the start is you have to know what the construct is. You have to know what you're measuring. And then you have to look at, to be very clear, where you're going to draw your items from. So within the study, we used the WHO 1995 definition of quality of life, because that was what we wanted to measure. So we needed to have a definition of what it actually was. So the WHO defined it as an individual's perspectives of their life situation based really around including, say, like culture, their goals, their concerns. So that was the frame that we took it in. So like as a construct, quality of life is multidimensional. It involves a significant number of aspects, say, for example, physical health, but it's not just solely physical health, psychological constructs, and it's not solely that either. It spans both. And also, acknowledging independence, social relationships, and environments. Those are all aspects of quality of life that need to be taken on board. And health-related quality of life we were going to be looking at in the item. So that sort of is a further funneling down of quality of life, looking at it from a health-related perspective as well. So the domains that affected that. And Karimi and Brazier, they actually identified that, it's a bit fuzzy, the line between the two. It's not very clear, quality of life here, health-related there. It blurs, the line blurs between the two. And really, it really matters, the definition of quality of life for Qualten, because we wanted a valid outcome measure. So we needed to have a very definitive idea of what we were looking at. And also in constructing this instrument that we wanted to do, DeValis was very clear, that it has to be evidentially, based, theoretically and evidentially. So we needed the wider literature. We needed to support it. It was the third leg of the stool, that would give us that, balanced instrument. So basically our starting point from the literature was appraising the evidence that was already there, both from the health-related quality of life, but also from general quality of life as well. So we did 2 systematic reviews, glutton for punishment. We said, no, I don't want to do 1, we'd do 2. But the reason that we did 2 was quite important, because one wouldn't have given us all of the answers. Like I said, we were looking at quality of life generally, and then with a more focused health-related quality of life. So we did an umbrella review, because that was giving us the breadth of a view of quality of life across all dermatological conditions. And as you've heard, SJS 10 is quite a rare condition. So therefore, the literature on it is quite limited. So in order to construct our instrument, we needed to have you know, the domains, dimensions, etc., that were identified across dermatological conditions, so that we could actually use them for the scaffold to then populate with the disease-specific, you know, ones that would give us the final outcome. So the umbrella review was going to give us that broad, you know, dermatological view across all dermatology types. So we were going to be synthesizing the evidence from other reviews as well. And then we did a mixed method review. And the mixed method review was on the health-related quality of life experiences of patients. So that was going to give us that disease-specific lens that we could then extrapolate into our wider framework. So an umbrella review, really, the overview of it, we were going to examine the evidence base around the constructs, the concepts, the attributes, the dimensions and subdomains of quality of life as they relate to adults with dermatological conditions. Just think, did I? Oh no, sorry, I thought I'd skipped a slide. So the umbrella review, we undertook this. So this is a review of reviews. So there was a lot of information out there. We were looking at the instruments that were already there. There was a significant amount. There's a very small amount of information around SJS10, but the information on dermatology is huge. You know what I mean? It's quite vast. So we undertook an umbrella review. We registered it in Prospero, and methodologically we followed the JBI umbrella reviews methodology. So we searched 7 databases, again, which was quite significant. And again, Liz Dorr and Isabella were the information specialists that, you know, and it was quite a significant undertaking that. And we also looked at the grey literature. We didn't have any language restrictions, and we had no time limits either. It was from inception to April 2025. And we appraised all of the evidence with the JBI critical appraisal tool. So, and again, our processes, we were quite systematic and thorough in our processes. We had dual screening at all levels, both title and abstract, full text, and at data extraction. And this was because of, you know, the rigorous nature of developing the items for the instrument. And I suppose in relation to an umbrella review, just to think about it for a moment, because I want you to understand, I suppose, the strength of evidence that went into this. So an umbrella review really is a systematic review of systematic reviews. So the information that you're dealing with has already been through a very vigorous process where all of the studies have gone through critical analysis, you know, before they were incorporated into reviews. And the diagram there on the left, the evidence pyramid that you're used to, normally evidence, the hierarchy of evidence would show primary studies at the base of this. Up near the top is systematic reviews and meta-analysis, and umbrella reviews sit right at the apex. So they're the highest level of evidence. So when you're doing an umbrella review, really, you're standing on thousands of, you know, primary studies that have been included in those reviews. So the strength and the, I suppose, you know, the level of detail that has gone into that is significant. And that was really important for us. So it was right for our question, really, because, excuse me, we wanted some mature evidence that was, you know, these were going to identify outcome measures that were already being used across other studies, so that we had a very mature evidence base, and that would allow us to borrow those constructs that were already, you know, had validity tested in other studies. So it was important from us on that. So on the PRISMA side of things, we started out with just over 11,000 studies. After duplication, 9,379 went to screening, and then 539 went to full text screening. And we ended up with 128 systematic reviews and meta-analysis were included in the final studies. So they were mainly from UK and the US, but there was actually 12, you know what I mean, say like countries that they came from. But within the reviews, like virtually every geographical, you know, global region was included. The the reviews themselves maybe came from the UK or the US. And there was over 1,000 patients were actually included in that. So that's quite significant. Tell a lie. There's thousands in this one. There was 1,000 in the mixed review when I come, but it just shows you the strength of evidence. That's what's actually happening. So within the reviews, what we found was that there was 54 different dermatological conditions included. And the data, the main studies, the included studies came between 2002 and 2025. There was 54 distinct dermatological conditions, and they ranged from, say like acne, psoriasis, etc., across the different spectrum to rare diseases and many more. As I said, the geographical distribution was chiefly in the USA and the UK, but there was, geographical spread quite nicely. There was 296 different quality of life measurements that was used across those studies. So that was huge. That was the amount of different instruments that were used to collect quality of life from the individuals in it. The most frequently used ones were the DL, so that's the dermatology level quality. Yeah, thank you. 54 of the studies had used that. 53 of the studies had used the short form health survey, the 36 item one. And 33 had used the what's that one, Sheila? Euroqual, the 5-dimensional one. And Skindex, which is a skin-specific one, was used in 32. But a lot of the studies used a combination. They didn't just use one, they used more, and some other little maybe bespoke ones, etc. So there was quite a mixture. But the stark finding really was in all of those 296 items, not one of them had ever been tested or validated in SJS-10. So it was a critical finding, really, and it really highlighted the need to develop, the bespoke tool that we were looking at. So what did we find? When we looked at it, we were looking at it and we were thematically analyzing what was found there, because we needed to put it in. And so we came up with 4 themes, and these were very consistent across all of the studies and across a huge variety of different type of dermatological conditions. So there was the psychological impacts, physical functioning, sexual and intimate relationships, and social and occupational impact. And these mirror what you've already heard in terms of the clinical picture, the experiences, etc. So the psychological, including anxiety, depression, self-image, self-esteem, physical functioning, pain, itch, fatigue, visible lesions, sexual intimate relationships, again, body image, partner concerns, social and occupational, the impact on work, education, relationships, family, finances, and activities of daily living. So those were very consistent across all. So they became then the start of our framework for our Qual10. And each theme had subdomains. And again, into the subdomains would fall, as you say like self-image, self-esteem, physical, appearance, etc. So we moved on then. So we had the themes identified. So we moved on then to identify how were we going to extract the theme. So we used that as a framework to extract the items into. So the first step of the process was the data extraction, and we used a JBI standardized tool for extracting. We extracted in pairs, and again, we did that individually, and then we compared, and any disagreements, there was a third arbitrator. So what did we extract? We extracted 4 different things. We took the quality of life instrument that was used in the study, their domains and subdomains, and any item content that was specified within it. Sometimes they weren't specified, it was just the domains, but wherever the item content was given, we took that, and the reported findings from the review itself in terms of the experiences of the impact on quality of life. So that's what we extracted. So then we started coding against the themes. So the items that were pooled, say like across the 296 instruments, we extracted those out, and we coded them into the 4 themes that I just showed you. So we used that as the framework in which to code it in, and then we mapped the subdomains within each other. So then the 4th step on that process then was, say like there was some that where they were merged, where you merge codes together, where they were, quite similar, etc. So we moved that on then, and those became then the draft candidate items for the actual instrument. So that was the output from the work package 1. It gave us the framework, it gave us the 4 themes, and it gave us some draft candidate items that reflected general dermatological quality of life measures. So what we wanted to do then was to populate it also with the SJS-10 specific items. So in our mixed method systematic review then, the aim of that was to look at the impact of SJS-10 on the health-related quality of life of these individuals experiencing it. So again, we went down through a systematic process. We registered it in Prospero, and we followed the JBI methodology of convergent integrated approach. So it differed from the umbrella review approach. But we used the PRISMA 2020 reporting mechanism. Now, again, Liz and Isabella were involved in the searching of this, and we searched 15 international databases here. And again, plus the grey literature, and from inception to November 2024. So it was a significant searching task. The quality appraisal, we used the MMAT. And again, so like we did this because we needed the SJS-10 specific items that we could populate into our thing. And I suppose the evidence from SJS-10 is much less than the broader dermatology. So it's coming from a small pool. We did a mixed method because either quant or qual on its own wouldn't actually have answered the picture. So we did the mixed method to look at the 2. So from a PRISMA perspective, so like we were dealing with maybe half the amount of studies at the start, again, because of the reduced size of it. So 157 studies went to full text, and we had 26 studies included in the actual review. 22 of them were quantitative and 4 were qualitative. And what did we, in terms of the findings, we had 3 themes that were actually identified from the synthesis. Because it was a convergent integrative piece, so what we did was we separately analyzed the quantitative and the qualitative, then we qualitativized the quantitative. So by that means you turn them into descriptive. So say, for example, if a study reported that 60% of participants had ocular involvement, we would turn that around, make it a descriptive theme, and then you could pair it with a participant quote from the qualitative studies that gave the experience of what it was like for, ocular involvement. So that's how we pulled it together. And from that synthesis, we had 3 themes. So the first one was physical sequelae, and that was evident across all of the 26 studies, both quant and qual. Ocular in 17, dermatological in 11, oropharyngeal in 7, and genitourinary also 7. Psychological sequelae, anxiety, depression, PTSD, fear of recurrence, and fear of medication. And sociological, then work, education, relationships, daily activities, and finance. And here you can very clearly see, like if we had just depended on the general quality of life, we would never have got the fear of medication, fear of recurrence. So and it wouldn't have been specific enough for it to be used as a tool within that. So I suppose one of the key contributions of this, it's actually the first mixed method review of SJS-10 and its impact on health-related quality of life. And it also confirmed that SJS, and Pauline alluded to it earlier, it's both acute and chronic. The impact of it can be chronic. And again, it surfaced the domains that don't, as I say, appear in the general literature. So again, in terms of how the items were extracted, we used the mixed method extraction tool. We extracted both quant and qual. Oh, I've told you this already. I'm a bit premature, apologies. So the quantitative findings, I say, we transferred them into descriptive codes, and they anchored them obviously to the review question, and then we thematically pooled them, you know, putting them into descriptive terms, and then pooling them with, if there was available, a descriptor from the qualitative. And we ended up then, our fourth step was the candidate items that were very specific to SJS 10. So, and again, this is just giving you an example of some. Now, some of the items came specifically from the umbrella review. Some came specifically from the mixed methods review, and some came from the qualitative study. Some were present in all three. So basically, and if they were, then obviously it was an indication that the item was much stronger if it was evident in all. So, and this is just an example of some of the one that came from the umbrella review, say like things like, you know, general things like, you know, didn't like the appearance, the self-confidence affected. The mixed method review then pulled out the SJS 10 ones, afraid of recurrence, genital area affected, vision affected. And the qualitative study, again, was grounded in the patient voice. So that was like flashbacks, you know, the PTSD piece, scared following discharge from hospital. And I'd like information on each stage of the 10 to be clearer. So basically, from the review, there was some items then that were pooled. So what we ended up with was 102 initial draft candidate items. And these candidate items then went into a process that Pauline is now going to go through with you, which would be the, say like duplicate items were combined at that stage. And then they went to the steering committee for validation. So there was face validation done. And then they went into the Delphi process to actually be highlighted. So I'll hand over to Pauline to follow on the story.
Thank you. Thank you very much. I'm conscious of time. Are you all okay? Yeah, okay. I'll be very quick now because I think we have time. We need to have time for our panel. So, as Pauline said, I talked, you know, about the items now developed from our reach reviews, from our evidence synthesis, and we had our draft items, and we had 132 of those items. That is wonderful. That's when I just number three. That's it. Perfect. Wonderful. Lovely. Thanks, Emer. Thank you very much. So this is where Raj spent a lot of time in my office, or he didn't. He was on fine really a lot of time. And so we had to do a 3-round consensus study. So we had our items, we had our 132 items, but before 132 items, if you were trying to get consensus in 132 items, you'd be still at it, I'd say 5 years down the line. So we did our face validation. We did 2 rounds of face validation and that, and we reduced it down initially down to, I think it was 98 items, and then eventually down to 76 items. So the aim of your consensus, the 3-round consensus, is to get the consensus from an expert panel in relation to these items. So that's really important. So you have your items, know how to publish that, you have to have consensus from an expert panel. And that's very important of the DeVille and Mo King's literature on developing an outcome measure. So again, we got ethical approval. I'd say the ethics committee were sick of looking at me. And we commenced the study in March 2024, and we completed in July 2024. So we did it in pretty quick time. And Raj was absolutely fantastic in getting the Qualtrics and all of that. And I was the one that was checking it and getting back to him and said, that's not right, this isn't right. And we sorted all of that out. So I was a devil Phil, making sure that everything was perfect. So the first thing is we had to get an expert panel. I was so fortunate. This was one thing that worked really well. And Sarah and Saskia put me in contact with the European Reference Network, the ERN Skin, and I had 76 members. The majority of 37 were dermatologists. I had allerologists. I had 9 SGS survivors, ophthalmologists, 4 dermatology nurses, a burn surgeon, a psychologist, and a gynecologist. The first round, I'm flying through this now, so bear with me. So the first round, and it's easier, and you're so dependent on people responding back to you when you're sending out a Delphi. So the first round, we had all the items and giving clear directions and up to the people or to the respondents was really, really important because they came from all over the world. This expert panel were from all over the world. So the first thing they had to do was to rate each item, the 76 items, according to importance, first being of no importance and 9 being of extreme importance. For the participants who are healthcare practitioners, they had to rate the importance in relation to their experience of working with patients, and for patients from their own personal experience of having the condition. They were also asked to suggest any additional item that they felt we forgot or didn't include. And that actually was quite a good thing to do. So the results of that, we had a 70% response rate for this, and we used the mean score of above 6.5 for an item to be included. This is where Ailish came in. Again, Ailish was always there in terms of I could email Ailish or Reamer, and we watched through all of this. So out of the 76 items, 40 items were retained. They had a score above 6.5. And we also introduced 5 new items. And for an item to be included, more than 2 people within the expert panel had to suggest that particular item. So we have 45 items going into round 2. So in round 2, do you like my little boxing ring there? So in round 2 then, the participants were invited to reassess the importance. This demanded a lot of work in setting this study up. So each respondent got their own, what they had given in the initial round 1, their own response. And they also got the standard deviation and the mean. And we explained that very simple, in simple terms, in case, because we're different people, with different understandings of statistics. So again, they had to reassess the importance of each item based on their own response and the response of the group. And they were also asked to rate the importance of the 5 new items. So the results of that, we had a 98%, it gets better. We had a 98% response rate in this, and this we used percentage agreement, a 75% percentage of agreement for an item to be included. So 2 items were very close to meeting the 75, there was 72% and 74%, and we spent a bit of time talking about this and arbitrating, and we decided to include both here. And so we had 21 items going into the third and final round of the Delphi study. So for round 3 then, there was 2 things that they had to do. So the first thing, they had to reach a consensus on the importance of the items, and also we had to determine the content validity index. There was a 94% response rate in this Delphi study, which was brilliant as well. These response rates were really good. This didn't just happen. We had to keep, reminding people, encouraging people to respond back. And I'd say to Raj, you sent out another reminder, didn't I, Raj? And it worked. It does work because people forget. They're very busy, but don't worry, we reminded them. So 19 items then were scored above the threshold of 75% of agreement. 2 items fell below that, but we actually included 1 because it was very important to patients, the patients that were responding here. So we had 20 items. That was the final thing here out of the Delphi study. And that was the actual 20 items at the end of the Delphi study. We had 20 from 132 down to 20. Not bad, Emer. That is good. So we published that Delphi study then in the British Journal of Dermatology as well. So we were getting our outputs, we were getting our work. We were busy. Me thought I was inside that office doing nothing. Now, so that leads us on to the next study, and I'll be very quick in this. The next study is where we had to test it. So we had our 20 items here, no good. Pauline said it's grand. No, we had to do a validation study, a retest study. So the aim of this was we needed to do exploratory factor analysis. We needed to determine the stability of quality by correlating the scores obtained on repeated administration. So this again was a challenging study. And we also had to determine the internal reliability and the convergent validity. Ethical approval could spend forever. You'd be bored to tears if I went on about ethical approval here. Ethical approval, again, I applied for that here, got it, and it was accepted by the UK and all of that. I got ethical approval. I had people brought in from the United States, from Nashville, so we got from the Vanderbilt University and also from the University of Cape Town. So I'm a dinger as ethical approval. Anyville, it's too late, I'm gone tomorrow. Okay, so a lot of ethical approval there. So the questionnaires we used, we had, again, Raj set this up in Qualtrics. I was there checking up. besides all of that, not alone that, Raj and myself, we worked with a company to translate this officially into, professionally into French as well, which took we followed the Seuss method. So that was quite a lengthy period of work as well. We could have written a paper on that too. So, and we also used a very detailed demographic questionnaire, which included clinical profile questions. We used the WHO Qualbref and the EQ5D5L, which included the VD, the EQ VAS, and we had a voluntary sample of a voluntary response sample of adults with a verified diagnosis of SGS, or 10 of 104. That was no mean feat for a rare condition. That was sleepless nights. Okay, because you were hoping to God you were going to get a decent sample, because if you didn't, the whole thing. Actually, after the Delphi study, I thought that was it. I wasn't going to get the sample. There was always a stress there, because if you don't have people, you don't have people. There isn't a thing you can do about it. So anyway, the data analysis from that, so we did the different tests. We did our exploratory factor analysis. We used our principal component analysis with varimax rotation, and we used the SCREE-COP then. That suggested a 5-factor solution, which was brilliant. And there was an overall percentage variance of 67.8, which is pretty good. And there was only one redundant item, so that left 19 items in the final document. For reliability, we measured in internal consistency using Cronbach's alpha. We got 0.87 across all of the 19 items, which was fantastic. But Ailish will say that was good. And the test reliability, then we used the interclass correlation coefficient. We had a result of 9.3 and a 95% confidence interval between 0.89 and 0.96. That's very good. And then for internal reliability, we use the person separation index of 0.87, and that's very good as well, if not excellent. Then we did convergent validity with all the other questionnaires, and we actually had a moderately strong negative correlation. And you're all asking, why was it negative? It was negative because quantum, the higher the count in quantum, the higher the number that you score in quantum, the lower your quality of life. Whereas in the other ones, the lower the measure, the lower your quality of life. So that's why we had a negative, just in case somebody was questioning that one. And so that led us onto 5 nice domains. We had a domain in relation to vision, called vision-related function. That's what we've called them. The second domain was psychological distress and fear of recurrence. Domain 3 is about intimacy and relationship impact. Domain 4 is continuity and coordination of follow-up care. And domain 5, identity, adaptation and advocacy. All these domain was a culmination of our clinical work, our qualitative studies, our evidence synthesis, our Delphi study, and that was the end product. So we ended up with a lovely, that's all the 5 domains and all our different factors. So we ended up with a quality of life outcome measure with 19 items. And there's your final product. And that is that. Yeah. So just to finish on, we have a panel discussion. I'm not too bad now at the time, a few minutes over. So this is the first bespoke, internationally developed and psychometrically validated health-related quality of life outcome measure for adults with SGS and TENS, which is brilliant for that cohort of patients. It should potentially help support communications between clinicians and patients in terms of discussing the impact of the condition on their life. It's a practical step in meeting SGS and TENS patients' needs by, again, assisting clinicians in developing an appropriate treatment plan. And it can be used, hopefully, to facilitate between or within treatment comparisons. We want this to be used. And I know Pauline will be continuing her work. I will be now, what will we call it? Might have a new role just at the other end of the phone. So that's it, really. So thank you very much. So I now we just have about 10 minutes of questions and answers. And Sarah, you're still with us?
I am indeed.
Lovely,
Yeah.
Sarah. So we're now going to have maybe questions and answers from the floor. And I'd say people are actually floored because they're wrecked. We gave them no break. They had to work through this the whole time. So we might turn on a light.
Lights are allowed now.
Lights are allowed now.
The pictures
If you want to sit over here for the panel.
I got something on my own. You know me.
Oh, that's right, isn't this means, yeah.
Okay, everyone, thank you so much for your attention and for staying with us, even though the sun is beautifully shining outside. So you've heard, the story from start to finish, really, and how the different aspects impacted. So is there any questions from anybody or any?
Hi, Pauline. Then can I just compliment you on the presentation and especially the structure of the presentation? It's such a brilliant overview. But I just want to ask in relation to the psychological care of patients in Ireland, like here or Limerick, do they get psychological care after they've had a diagnosis and discharge home?
Well, we're fortunate in Limerick in that we have access to a psychologist, which if you look at the nationally, dermatology departments across Ireland don't have. The only two departments that have direct access to psychology services are ourselves in Beaumont. However, even saying that, even the follow-up, it wouldn't have been routine up to recent times for us to follow up patients afterwards, unless there's complications. And that's why this work has been so important, actually, in highlighting it's not just an acute disease. And that's been a journey, because a lot of us, when I would have entered dermatology in the past, would have congratulated ourselves on, we've got the patient there now, we got them through it, well done, job done, off we go. And it's this work and others' work that highlighted it doesn't end with that one event, and that's I'm sure Rob and Phil would say it's important.
Exactly, yeah. Yeah, just after being in the hospital for the 6 weeks, I just felt like they were kind of left on their own then. And even for my parents, they were still, traumatized by the whole thing. So they didn't know exactly, there wasn't much support there for them. And the fear of reoccurrence is all for them as well. So that was always in the back of our minds. So that's why I was very interested in trying this research, because I felt like it was something that would be very helpful for anyone to go through it.
Thank you. Anyone else? And
Yeah, thanks. Congratulations, Pauline and everyone in the team. It was a fantastic piece of research and just really good seminar today as well to learn about it. I was just so interested. It's such an under-researched area, and that point you mean about the adjustments and the interview study, feeling sense of be grateful that it's a chance to talk about it. But I'm also really interested, Robert and Phil, from your point of view, being involved as public and patient contributors to the project. You had a different role because you were actually involved in the research team, helping the project from start to finish. So I'm really curious to know, did you like that role? And would you recommend it to other patients?
Yeah, I enjoyed the role. Like, I think it was an important role in the research, because it kind of kept research grounded and from the perspective of a patient as well. And so it was good to see all the research guys were doing, but it was also, having that input in it as well. Like, I think that was a very important part of it. And so reviewing papers and that, and just having my lens on it as well. So yeah, no, I enjoyed that part of it. Yeah.
Yeah, and I echo the same as what Robert said. Now, if my late mother was here, she would say, because the fear factor. So the fact that when I first got involved, and I said, look, that I was approached by the team to speak about it, and it was just like a trigger for her. She says, oh, no, because she just thought she was going back into that situation again. And I said, no, look, we need to give this information of our dealings with it. And actually, I meant to say earlier on above there, but I just got a little bit discombobulated above. Sheila was absolutely impeccable while we were in there, and you did serve both on the physical and the emotional side. Because there was times that Mem had confided to Sheila and said, I give up, let me go. Because I remember Sheila saying that to me, and that was quite difficult at the time to hear that, because your mother is your mother, and she had fought the sepsis. And this was on the second occasion now. She got the sepsis, or she got the Steve Johnson's tins. She got the Steve Johnson again. And I suppose she kind of said, enough is enough for me. And I think she kind of almost coached her to kind of, this is just... This
Full
is the
day
stage
at a time.
This is the stages of it, and fair enough. But to your question, yeah, it's cathartic for me. And I would actually hope that this really does help patients and families alike. I'm pretty sure.
And Phil and Rob had their first publication with BJD. And hopefully we have a second. Hopefully we have a second.
And there's an awful lot of dermatologists who want to do it.
Is there a financial reward? Your name's up in lights now.
Anyone else? Like Margaret is kind of the research method more than anything.
Yeah.
The video was kind of your guide in the quality of the eyes. Was the test validation part of that guidance?
But yeah, okay, yeah. Highly listed, yeah.
Right. A comment really is for Paulette and Sheila. Come into the practice, we knew this could go on in the background. And it's not often that we separate sometimes the university from midlife practice sites and don't see how they work hand in hand. All I could say is, wow, I knew the research was going on, but not to the level that you described, and international collaborations and all the cases that were bought, and such a massive research team, both here in university, the two callings, and then with the next in London. So it's a massive congratulations, because the impact is huge internationally. To go from zero to have an international working by scale, that's not small. And another person in the best book of the Richard Boys.
Thank you. I'm conscious of the time. Do we have any last question? Liz?
Yeah, I just wanted to say to Pauline, it's just fantastic and great to see it just from start to finish, and just to stand it at the detail of whether that's gone into it. I'm delighted I was here just to sit through. Fantastic. But
Liz, you were brilliant, too. You're not great.
thank you.
Great work with you.
And could I just take the opportunity as a member of the research team to thank Polly for her leadership and guidance, and Raj for his huge work. It's been fantastic to be part of the team, a real privilege and a real pleasure. And from all of us, Polly, we wish you all the very best.
Thank you.
Look,